programming, and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves on offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass.
And we're live in 5,
4, 3,
2,
1.
Well, good morning, everybody. Yes, we're live from the beautiful facilities of the Seattle Science Foundation. Today is May 2nd, 2025. My name is Jens Chapman, and the hat, my trucker hat, is there to symbolize we're actually here. And very proud and very grateful to welcome you to our journal club, which we got to host here today. And I want to thank all of you again for tuning in. Particular shout out to our good friend, Dr. Randy Davis, who's one of our Gold Pass members, and Dr. Thomas Riley, who's another Gold Pass member in the panel. And we look forward to your questions in the chat room or their direct contributions. Many thanks to those who support our mission to bring quality education to you, and hopefully we'll fulfill that premise today. It is very common that centers show off their surgical prowess with deformities especially, and sometimes motion-preserving procedures. Today, we thought we'd talk about an often overlooked population that is rising in numbers. That's spinal cord injury patients. You'll see some numbers later. But this journal club is about spinal cord injuries, specifically about 4 aspects of spinal cord injuries. One is a so-called Charcot spinal arthropathy or neuropathic arthropathy. The second one deals with spasticity after trauma, after spinal cord injuries. The third one will be around a post-traumatic syrinx formation. And the fourth aspect deals with neuromodulation and neurorehabilitation prospects that are evolving. So we have 4 great speakers. 4 of our fellows were so kind to take on these topics. And again, there'll be little case vignettes, and I'll call upon, I think, Dr. Nick Minisali, originally from Philadelphia, and today for the first time, not wearing Philadelphia Eagles green. So that's a new thing. What does this say? Newcastle. Okay, wow. So he has shed his Philadelphia Eagles thing about half a year after the Super Bowl. And Nick Minisali is going to talk about Charcot arthropathy. So Nick.
Thank you very much. Good morning, everyone. Still very much an Eagles fan, don't worry. So yes, I'll be talking about the surgical management of Charcot spinal arthropathy in the face of possible infection, which was published by von Glinsky, as well as Dr. Chapman and Dr. Oskouian from this institution back in the International Journal of Spine Surgery in 2021. And I have no relevant disclosures.
Can I say something? Can I say something quickly?
Sure.
So this is annoying if you go back to the title page. This is obviously a publication that came from here, but I'm going to say this right now and I'll say it later. There's not a lot published on spinal arthropathy, neuropathic arthropathy. So if this looks self-serving, you could say that, but there's de facto not a lot published on this.
Sure.
So I'm just gonna wanna make this disclosure of conflict of interest, but also statement of fact. Go ahead.
Great, thank you. So before we jump into our paper, I'll just show a quick clinical vignette. It's a 64-year-old male with a prior T9 Asia A spinal cord injury due to a motor vehicle accident back in 2001. And at that time, he underwent T4 to L4 Harrington rod placement. Here we can see images from our initial visit in the clinic, which was in 2020, with those Harrington rods and some concern for early Charcot, but no major need to intervene at that time. And then by 2025, with continued imaging and follow-up, close follow-up, the patient did have progressive Charcot arthropathy at this L2-3 with associated instability, edema, and osteolysis.
Just quickly, is this a Harrington rod, Jens?
No, it's not a Harrington rod, just to make very
sorry.
clear. This is a hook rod construct. It is done in the spirit of Harrington, but this is considered probably segmental fixation. It's a simple distraction device that was put in there with 2 sets of interspinous cable placements. So thank you for pointing that out. This is not a Harrington rod. You'll not graduate until you can differentiate a Harrington rod from a segmental rod hook construct.
Yes,
They look
thank you
very
for the
similar,
correction.
but there are some subtle differences, and we can talk about that later.
Okay, I appreciate that. Thank you. So jumping back to our paper, what is Charcot spinal arthropathy, or CSA? It's a relatively rare condition characterized by complex progressive destruction of the affected vertebral motion segments due to lack of protective proprioception, most often a remote complication of spinal cord injury. So coming from an orthopedic background, this can happen pretty much in any joint that loses its protective proprioception. As far as, it's estimated to generally affect 1 in 220 SCI patients, and it can lead to progressive deformity, instability, and potential for ascending neurologic impairment. Superimposed infection in the CSA zone can potentially lead to suboptimal management, such as unnecessary protracted antibiotic therapy, or predisposition of the surgical patient to hardware failure and pseudoarthrosis. So the purpose of this paper was to compare, it's a retrospective cohort study, and it was aiming to compare clinical and radiographic outcomes of surgical treatment in CSA patients with and without concurrent spinal infection. So as far as methods, it's a prospectively maintained database was retrospectively reviewed for all patients with Charcot spinal arthropathy between January 1st, 2006 and June 29th, 2019. Demographic data was collected, as well as the cause of the prior SCI, any prior surgical interventions, and known superimposed infections. Those with known infection, either pre-op or intra-op, with evidence of infection like purulence, underwent staged procedure and were compared to those without infection. Postoperative complications were also recorded. So with regards to surgical technique, in the infection group, basically it was always a posterior approach, removal of any prior hardware. Pathology and specimens were sent for microanalysis. Aggressive debridement and irrigation of the area, as well as insertion of a structural PMMA or polymethyl methacrylate spacer, followed by posterior instrumentation with primary closure. And then the second stage of that procedure was always nutrition optimization, 6 to 8 weeks of IV antibiotics, repeat tissue sampling at that stage procedure, again, lavage, and then removal of those PMMA spacers, as well as all the hardware that was put in during the first. Screws were then upsized by 1 millimeter if possible, and then insertion of PEEK or titanium corpectomy cage, followed by posterior instrumentation and primary closure. So that's the techniques that were used in the infection group. As far as the non-infection group, it was a single stage reconstruction of the anterior column with similar cages and similar posterior instrumentation. And here's an example of that. So 17 patients were identified and 2 were excluded, leaving 15 eligible. 11 patients were considered non-infected, or the NCSA, and 4 were in the infected group with an incidence of about 26.7%. Positive intraoperative cultures and surgical findings were consistent with infection were found in all of the ICSA patients. So all of the patients were confirmed with an Asia A grade injury, with thoracic level being the most common. And in 93% of patients, the index condition was a traumatic SCI. The lumbar spine was the most common location of CSA, about 80%. The average time between onset of the index condition and the diagnosis of this arthropathy was 27.9 years, and most commonly presented with progressive pain, sitting intolerance, and fever comprising the most common presenting symptoms. 5 patients were initially misdiagnosed and treated as osteomyelitis, of which 2 patients had superinfected CSA. So again, that points to how difficult it is to manage this initially. Other results, the average CRP in the infected group was 91.5 compared to 14 in the non-infected group. All of the infected group presented with gas formation within the disc space of the CSA zone, and only 45% of those non-infected had the same. Fistula tract or decubitus ulcer was the most common route of infection in our infected cohort. And the most common organism was Staph aureus in 50% of those patients. The non-infected group had a mean length of stay of 10.3 days, and an average ICU stay of 2.6 days, whereas the infected group who underwent stage procedures had a total length of stay of 14 days and 2.9 ICU days. There were 2 intraoperative complications, both were in the non-infected group. One was a hemothorax, which required chest tube and resolved after readmission to the ICU and the chest tube. Number 2 was the intraoperative durotomy, which was repaired intraoperatively and had no significant sequelae. There were 3 medical complications in the non-infected group as well, both related to hypovolemic shock or post-op tachycardia requiring blood transfusion. 5 patients underwent revision surgery, which is a rate of 33% during the follow-up, which was a total of an average follow-up of 15.3 months. And 3 total mortalities occurred. 2 occurred more than a year after surgery, and a panel deemed that these were not related to surgical care itself. So in conclusion, treatment of Charcot spinal arthropathy requires complex surgical decision-making. Superimposed infection may be identified either pre-op with our standard workup and intra-op. And if so, the algorithm would be best to use aggressive management with debridement, uses of a PMMA spacer, posterior fixation, followed by stage anterior column reconstruction, and quad rod lumbopelvic fixation. And there was no risk, there was no reinfection cases using this technique. If there's non-infected CSA, still poses significant challenges, requires multidisciplinary teams, and based on this paper, you can expect multiple days of ICU level of care as well as a prolonged stay.
Great. So we have about 5 minutes for discussion. Yeah, okay, so go ahead.
Yeah, so strengths and weaknesses. This is the first study to compare the infected versus non-infected Charcot spinal arthropathy interventions and outcomes. So that's a very, compelling argument there. Identification of the most common organism and sources of infection, I think, is very helpful because looking at just imaging of Charcot spinal arthropathy can, in several cases we've seen this year, I say that's obviously infected, but not necessarily the case. And so using preoperative imaging, labs, clinical acumen is very important. If there's a fistula tract or a sacral decubitus ulcer, that was the most common source of infection in this particular study. And so I think it's important to always use your clinical judgment and try and decide with a lot of these different factors if there is infection, and be ready to stage the procedure if needed. Some weaknesses, it is a retrospective study. It's a small cohort, but this is a rare problem. There's moderate follow-up, but it may miss some of the instrumentation failures. There's data to show that most of instrumentation failures happen within the first year, or 50% of instrumentation failures occur in the first year. So it's 15-month follow-up, so still moderate follow-up, but that could miss some failures. And then in this paper, there was no formal fusion analysis in either group. There were, I think there was only 1 revision surgery for loosening screws, but there's no specific reference to fusion rate. And we know that the best way to do that is with follow-up CTs, and that's difficult to obtain in patients who are doing well. So getting back to our case from the beginning, this patient had no signs of infection pre-op or intra-op, so he underwent single-stage intervention with posterior hardware removal from T7 to L2, a complete corpectomy at L2, partial corpectomy at L1 and 3, and cage placement with BMP, as well as extensive debridement and irrigation of that zone regardless with 9 liters of saline, and then posterior instrumentation T8 to pelvis with a quad rod construct. This is relatively recent, so As far as follow-up, there's not too much yet, but so far doing very well.
Great presentation. Maybe go back to one of the initial slides of that clinical presentation. So why did this paper matter? What was the goal of this paper? Why is this clinically so relevant?
I think the important thing here is identifying Charcot arthropathy, what it is, which was very helpful in the paper itself, explaining it, and then deciding on your intervention based on if there's infection or not, and how to help work that up and what to look for.
So the point for me is, and this goes to just the message, but the reality is the following, and this is what we've struggled with. That includes our prior paper from Harborview, where Brad Jacobs was the primary author in Journal of Neurosurgery. The main problem for these patients is that, first of all, there's a lack of clinical awareness of Charcot arthropathies in the spine. And I think it doesn't just include spinal cord injury patients. It can be other clinical circumstances that create a neuropathic arthropathy. Number one. Number two, radiologists will read this as a potential infection. There's usually this osteolysis and amorphous osteoblastic response present. And the sequela is that infectious diseases gets involved, and then there's an endless series of needlings that takes place with these patients. And because it's a, quote, presumed infection, patients are put into braces and get extensive antibiotic regimens, which do not help these patients. This is a combination of a mechanical derangement and a desperate attempt of the body for stability. And it's a destructive process, and it's not amenable towards bracing with current insights, at least. So our infectious disease colleagues, I'm belittling them here a little bit, are valuable and are highly relevant, but this is not primarily an infectious problem. This is a secondary infection, and that's why this is relevant. And this seeks, with the small number samples being a limiting factor, to kind of elucidate that recognizing Charcot arthropathy is the first important step. And then secondly, yes, there's an infection, but there's a tool that we as surgeons have to kind of control this infection extremely efficiently with debridement, temporary stabilization, antibiotic cement placement, and then a staged reconstruction. That's the, sorry for editorializing. Dr. Abdul-Jabbar, so you've taken care of some of these patients since you've been here. Any thoughts on this paper and what we can learn from this very limited retrospective clinical series?
Well, I think it just goes to show, excuse me, how uncommon these are. Going back the span of years that it takes to get this small patient population, right? So these aren't people that are going to walk in your door regularly. So you may not see one very often, and I think it's very important to have this to know how to approach it. So when you see these patients, you have to have very high suspicion for infection, even though they may not be presenting that way. Or on the contrary, like you said, assuming that it's infection when it's actually not. So, these patients are out there, they're largely asymptomatic until there's a bigger problem. And knowing that, I think one of the things that we didn't talk about here is using a quad rod construct for pelvic screws is really critical because they don't have that muscle support to support the hardware. So, I think this is a great study because there's just not a lot of literature out there.
Yeah, it's not a primary journal, but it's PubMed listed. And there are four, by the way, there are 4 pelvic screws, 2 are just superimposed there. Yeah. Dr. Oskouian, you had a case recently with a Charcot arthropathy that was just that scenario. There was, the patient was super sick and was in the fangs of our infectious disease guys, and they wanted us to just, maybe you can just rehash what they told you to do.
I mean, they wanted to just have us debride it, but clearly it was a Charcot arthropathy. Unfortunately, she was more complicated. She had decubitus ulcers and a super infected wound and came in with sepsis. But I actually just saw her yesterday, Jens. She's doing, knock on wood, the incision's healed. She's actually doing great.
But you almost had to strong-arm the infectious disease doctors into saying, no, this actually needs a proper debridement and stabilization.
Yeah, they don't understand the actual biomechanics of what's going on.
So this is a big deal. And then the final thing I'd like to say to that, and this is, again, sorry, an editorial comment, is after surgery, these patients need to go to spinal cord injury rehab because they'll need to change how they transfer Frequently, when you look at where did they get to this situation, they did not have proper transfer skills and mobility aids. They did not have standing frames and proper, for instance, sliding boards and things like that. They whip their bodies around. They do very punishing things, and then the spine destroys itself. So they need to go back to rehab. To the nihilists who say this is actually a good thing that they get this false joint, these patients get sick, and they get sicker and sicker. This patient is an admirable patient. He actually was treated in LA for his injury. He never had spinal cord injury rehab. This is a former martial arts instructor and a boxer, very cool guy. And he lived by himself, basically, and then moved up here to be with his sister. And he lives by himself and has a nice car and makes a living. But he just got sicker and sicker. And this is a physical specimen, this guy. He got really sick. And it's a probably viscerally communicated mediation, neurologic mediation that leads to this illness. But it's pretty interesting. Or they get infected. They get super infected. Thank you for introducing to this. We're a little bit behind time. And I think next is Dr. Colin Gold for the topic of spasticity. We're not going to applaud right now. Dr. Colin Gold's a neurosurgical colleague who came to us from the University of Iowa. And as he's getting ready for a spasticity presentation, we also want to welcome Dr. Imran Fayaz and Dr. Luis Quartararo to our Gold Pass panel. Thank you, and Dr. Randy Davis and Thomas Riley for supporting us. And there's something in the chat room. So Dr. Davis asks, many Charcot patients without infection have elevated SED and CRP. Any labs helpful to diagnose infection? The most common thing by far, Dr. Davis, thank you for this great question, is urinary tract disease. It can actually be helpful to get either an IVP or a urology consultation. Interestingly, sometimes a TC99 scan, which, as you know, the TC99 gets eliminated through a urinary tract, can show you renal calyces or cysts that retain urine. So looking at the urinary system is good. And ultimately, a surgical exploration and washout will tell you if there's flake and pus in there, a staged reconstruction with antibiotic cement and temporary stabilization until the patients are built up again can help. I also like the albumin level as a simple screening test, and if they're below 3.2 grams per deciliter, they are in a catabolic state and probably need to be built up before a final reconstruction. Great question. Ultimately, it's a gestalt, but you saw on the lab levels presented, if the CRP is extraordinarily high, they probably have a super infection in there. Dr. Gold, spasticity.
Thank you. So we're going to start with a short clinical vignette. This is a mid-50s-year-old man who presented to clinic with 2 years of left greater than right lower extremity pain and weakness. Additionally, complains of difficulty with gait instability that's been progressive over time and spasticity involving both of the lower extremities. On further history, the patient was in a motor vehicle collision 2 years prior to presentation in Samoa, was never treated for anything at the time, and then he started developing these bilateral lower extremity symptoms. And then the patient had no symptom improvement in the presence of physical therapy. On the right, there is a lateral X-ray that was taken later on, but there was a similar one from prior showing a T10, looks like a compression fracture, at least on the initial X-ray. So physical exam, the patient has hyperreflexia in the lowers, 4 beats of clonus bilaterally. And you can see he has weakness in hip flexion and abduction on both sides. So this is an MRI showing that area from before. There's a T10, T11. It was probably a flexion distraction injury, though the actual injury happened 2 years ago, causing pretty significant spinal canal stenosis, cord signal change. And you can see a bit of acute kyphotic angle at that level right there. So surgery is done. He had a T9 to T12 laminectomy, T10, T11 intradiscal osteotomy with placement of bilateral expandable cages, and T9 to T12 posterior fusion. Postoperatively, at his most recent clinic follow-up, the patient's lower extremity spasticity had completely resolved. The leg strength and balance were both improving, but not back to 100% yet. And the patient was ambulatory with the assistance of a cane, which was slightly better than beforehand. He was dependent on a walker. So that was just an intro to the main topic, which is spasticity. The paper that we'll be discussing is early predictors of developing problematic spasticity following traumatic spinal cord injury, a prospective cohort study. And this was done by a group out of Vancouver. So for background, spasticity develops in 71% of patients who have experienced a traumatic spinal cord injury. This paper will focus on something they call problematic spasticity, which they define as causing functional limitation or requiring treatment. And this occurs in 41% of patients who have a spinal cord injury. And the objective of the paper is to identify characteristics of patients at the time that they leave the hospital from the initial presentation that will be predictive of future problematic spasticity. And they break that down into two groups, either spasticity that requires treatment or just a spasticity that limits quality of life. So again, this is a prospective cohort study. The population includes all patients enrolled in the National Rick Hansen SCI registry at the Vancouver site. Eligibility criteria are all patients over the age of 16 and enrolled in this database. Exclusion criteria are death prior to discharge, that's of the initial injury, and no spasticity data available. Spasticity was measured at 1 year, 2 years, 5 years post-injury using the Spinal Cord Injury Health Questionnaire. This is a patient-driven questionnaire where they answer the questionnaire themselves. There's no physical exam associated with this, which we can talk about later. And then statistical analysis was done using an inverse probability-weighted logistic elastic net model. So here's their flow chart. You can see 917 patients overall showed up at this trauma center in Vancouver. 51 were excluded for death in the acute or subacute area. 866 were alive at discharge. However, 6 of those were excluded for being under 16 years old, which leaves 860 eligible patients. 395 of them were not consented, and then 465 were consented. And then data was not available in 115, leaving the final N of 350. So here are the results. As I mentioned, 2 different main categories that they're looking for results in. This is characteristics predicting increased spasticity requiring treatment. So the 5 things they found to increase the odds ratio of needing treatment for spasticity were moderate GCS in the field, which they defined as GCS of 9 to 12. Admission to rehab after leaving acute care rather than directly to home, prescription of spasticity medications at the time of discharge, moderate pain during activities, and PSFS of 1 or PSFS of 4, meaning they already had spasticity of some degree before leaving the hospital. And on the right, I just put little arrows next to the little odds ratio brackets that they show. And then the second part of what they were looking for was spasticity. I think I mislabeled this. Oh, sorry, no, it's the same thing. This is still spasticity requiring treatment, and these are the negative predictive values. So neurologic injury level of L1 to S1 and motor level of L1 to S5. You're less likely to need treatment for spasticity. And then the other part of what they were looking at was spasticity limiting function. And again, this was self-reported. So then they found 9 variables that were increasing the likelihood of this to happen. Again, moderate GCS in the field, admission to acute rehab, PSFS of 1, 2, 3, or 4. So really any spasticity at all present at the time of discharge. Again, spasticity med prescription at discharge. Increase in AIS motor score of at least 20, meaning the patient's strength actually increased over the time that they were in the hospital. AIS grade of C and severe pain affecting quality of life, severe pain affecting sleep, and moderate pain during activities. And 3 results they looked at found decreased likelihood of spasticity that limits function, and that's older age, neurologic injury at 2 levels, one being between C1 and T12 and the other between L1 and S5, and motor level of L1 to L5. So overall, they used this statistical model to create a prediction method. So this is an example of the nomogram that they created on the right. And this one is for spasticity requiring treatment. They found a ROC for the development set of 0.8 and the validation set of 0.85, both of which are considered very good. And I'll show how this is used clinically. Next slide. And then this is the model for prediction of spasticity limiting function. And again, ROC is good with 0.81 in the development set and 0.84 in the validation set. So this is not a real life example, but a hypothetical patient showing how they would use this nomogram. So you can see you take the patient's data in these various categories, and you plug them into this kind of flow chart, and each data point gets a point on each of these scales. So for example, age, you take the patient's age of 25 and it gets 18 points. So the point scale on the top, you kind of line that up with where age would be, and then that determines the amount of points for that variable. You overall add those up at the bottom and you get a total score, and that predicts the likelihood of spasticity. In this patient's case, 96% chance of spasticity limiting function. So overall, they determined that for a given AIS grade, a greater improvement in motor score was more associated with greater odds of problematic spasticity at the time of follow-up. Among patients with motor score improvement, patients with AIS grade C, problematic spasticity at the time of discharge and who were discharged to a rehab were more likely to have problematic spasticity. They quote another article, Dvorak et al., which showed similar findings in central cord patients with lower quality of life despite greater motor score increases when problematic spasticity involved. I think this expanded on this paper nicely because they actually had quantitative data for quality of life and kind of tying it into the very subjective and self-reported nature of these findings. Their pathophysiologic rationale for this finding is that motor neurons can become maladapted to the loss of supraspinal input following spinal cord injury, resulting in uncontrolled muscle activation. And obviously, the more motor neuron function you regain, the more likely this is to happen. And then they found that the relationship between spasticity and pain is very complex because either can precede the other. But this study, as well as others in the past, have shown a clear link between the two. The more pain, the more likely spasticity is to be present.
This is a wonderful set of 2 insightful sentences. It's just black and white here. It's very, very meaningful. Each of those is critical to understand. Do you have more slides?
That's it.
Thank you. So can you go back to the initial case? So quickly about that case, why I thought this was interesting. Go back a little more. This is the most innocuous T10-11 fracture. The patient was actually sent to me from go forward to that MRI, was sent to me from a Pacific Islander surgeon who consults on the islands, and he basically said this patient actually has a grade 1 spondy at 5.1 and a 4.5 moderate stenosis. And he said he needs an L4-S1 fusion, sent it to me for that. And I examined him, and he had this hyperreflexia, and it just did not make sense. And this is an extremely stoic warrior type person. And he had spasticity, which did not make sense. At the very upper end of the lumbar sagittal, there was kind of a question of something didn't quite look right. So we got this thoracic imaging that he had approved by his community, and we saw this stenosis. And again, this was his real problem. But the problem of spasticity is it's not painful usually until it becomes kind of really bothersome. But by itself, it's not painful. So people interpret what's going on with spasticity. So for me, the main take-home point is understanding and examining for spasticity, doing a better job documenting it in a consistent neuroexam, and educating patients and their families for secondary evolution of spasticity, but taking it seriously. At the University of Iowa, where you came from their wonderful neurosurgery program, did you routinely put patients with spasticity after spinal cord injuries on an anti-spasticity drug, or how did you handle the prevention strategies of spasticity?
Yeah, we certainly did. We had a PM in our team that were the kind of gatekeepers of all of that. So we were aware of kind of all the various medications, which there were many, that it was kind of the standard profile that all these patients are put on, but not really driving the ship. But yeah, anti-spasticity medications were certainly involved.
And then one thing that we cannot talk about this morning, there's so much to talk about, is autonomic dysreflexia, AD. So again, any thoughts on AD and spasticity? Is there an interaction? Is there an interplay of this autonomous dysregulation and spasticity or secondary spinal cord injury sequelae?
I don't really know the answer to that off the top of my head. I would think it's level dependent somewhat.
Yeah, no, it's another one of those viscerally communicated maladaptions. And so spasticity is important, but having an education, I know this is not directly applicable to your talk, but indirectly, being AD aware and making patients and their families, as well as care providers, AD
It's more
cognizant.
common if it's T6 or higher. Yeah, it's more common if it's T6 or higher. Typically, T6 is kind of the cutoff.
Is that sympathetic? Is that due to sympathetic
Yeah,
input
yeah.
or cord mal-regulation?
It's loss of the sympathetic tone, and you get uncontrolled hypertension.
That's excellent. Thank you. Great job. Next, we'll go to the topic of post-traumatic syrinx. Really well done. Thank you, Colin. Dr. Mark Kramer, a neurosurgical colleague from the University of Wisconsin, another preeminent neurosurgical program in our country. And I want to, again, welcome all of our friends and supporters from around the world. And thank you for your interest. And hopefully this excursion to the world of spinal cord injury is very relevant to you and will help you in your awareness raising of the plight of spinal cord injury patients. Dr. Kramer.
Excellent, thank you. So no disclosures for myself. We'll talk about post-op or post-traumatic syrinx formation among spinal cord injury patients. So just briefly, I'll just review a vignette from a patient that recently came to our clinical attention. It's a gentleman who's 6 years old, approximately 6 years old. He had a motor vehicle accident about 20 years ago, Asia A spinal cord injury, estimated around T6. You can see he had this previous fusion here. And you can see he's had some imaging over time. In fact, 10 years ago, had this MRI, it shows this large syrinx, kind of posterior to the C6 vertebral body. And the reason he comes to clinical attention now is that he's having some worsening sensory changes in his arms. And here's his repeat MRI, which at least on initial review looks pretty similar actually. But the details are a little more murky when you start looking a little lower down, and you see that, again, comparing the thoracic spine MRI, T2 sagittal here, you can see that there's a new syrinx that extends all the way down to this quite large disc herniation at T910. And again, he's having these new clinical symptoms. This case is, at this point, unresolved, and we've kind of discussed some treatment options with him. So to get into the topic, I'm talking about post-traumatic syringomyelia. So what this is a normal cystic dilation expansion of the spinal cord. The pathology can actually be seen in many different situations, not just limited to these post-traumatic situations. It can be seen in hindbrain deformities like Chiari malformation, tumors, infections, tethered spinal cord can also cause syrinx formation. The formation of syrinx is ultimately thought to be occurred due to alteration of CSF flow through the cord. So on the right here, I show an image of the normal CSF flow patterns around the brain. You can see it's CSF is formed by the cord plexus, circulates through the ventricles of the brain, ultimately exits out through aqueductus sylvius and foramen magnum D, and extends down into the subarachnoid spaces of the spinal cord. And the base of the spine ends up being considered the fifth ventricle, a large area where CSF can deposit, and it's an important part of this normal physiology. Spinal cord injuries are a unique etiology in regard to this pathology. And that's owing due to the amalgam of the events leading to the formation, likely a combination of mechanical alterations and inflammatory processes. So first of all, spinal cord stenosis and bony deformities occur after spinal cord injuries. This is well known. Oftentimes requires surgical fixation. The second thing that happens is there's contusion, hemorrhage, and the resultant biomechanical alteration in the environment around the spinal cord. This leads to scarring, arachnoiditis. And these two concepts ultimately sometimes are actually quite related. So as you see more advanced scarring, arachnoiditis, you can actually see tethering of the spinal cord, which can exert tension on the cord and actually promote syrinx formation as well. So if you look at the literature as a whole, there's many case reports of this particular phenomenon after spinal cord injuries. Generally reported 3 to 9% clinically, but radiographically much more common, up to 30 to 50% in some case reports. Patients can often present with pain, sensory-motor symptoms, weakness, sensory changes. They can also present with bulbar symptoms, as in lower cranial nerve dysfunction. That's potentially secondary to some tension, tethering of the spinal cord. And the median time to diagnosis is quite lengthy, actually, 9 to 15 years, at least according to the literature. Much more common in the thoracic spine as opposed to the cervical spine. And there's a variety of treatment options. Generally speaking, consist of detethering or lysis of adhesions, trying to recreate normal CSF physiology around the spinal cord. Shunting has been tried. Shunting can be performed from the syrinx into the lung space, the pleural cavity. It can also be performed into the subarachnoid space, which we can talk about later, but can be a little problematic. And of course, surgical correction, as this image here shows, can be important as well to kind of recreate the normal physiology of the CSF flow. So to get into the paper, I figured in keeping with our pivot to Rio for the AO Congress next month, we could talk about this fairly recent retrospective review of post-traumatic syringomyelia from a prospectively maintained database from a rehab group in Brazil. So the question that they asked is, among adult spinal cord injury patients treated at this rehab center over approximately a 20-year period, what are the prevalence, risk factors, and etiology and imaging features of these patients? And additionally, among those that underwent surgical intervention, what was the clinical and radiographic outcome? So here's their flow diagram. They identified 920 patients over this period of time with spinal cord injuries. Inclusion criteria, adults, of course, spinal cord injuries, and then they specifically looked for radiographic evidence of syringomyelia, which was confirmed on MR imaging. And of course, they went further back into their charts and looked at clinical details, demographics, and then they performed some radiographic assessment. So in terms of prevalence and demographics, this table on the left, you can see that male gender, in keeping with general trends of spinal cord injuries, much more common, 75% of the patients were adult males, and the most common etiology was motor vehicle accidents, almost 70%. And among those that developed post-traumatic syrinx, majority, 63%, were Asia A injuries, very severe injuries. And also in keeping with the literature, thoracic region was much more common, with almost 66% of these patients having an injury in the thoracic region. In terms of clinical symptoms and need for surgery, 48 patients went on to receive surgical treatment, and they highlight the clinical symptoms among those patients were most commonly upper extremity paresis, pain, as well being the second most common thing. The operation of choice was most often shunting, syringopleural shunting, and followed by lysis of adhesions. The symptom onset timing, most of these patients were multiple years out from their injury, but earliest patient within the first 1 or 2 years, and all the way up to 13 years, with a median of about 5.5 years. It's a little unclear if there were any symptomatic patients who elected to forego surgery based upon what was published in the report. Furthermore, there's little detail on whether the remaining 37 patients who did not undergo surgery were symptomatic. So in terms of the radiographic results, these two figures demonstrate that, so they looked at cyst size based on MR measurements, and they also looked at cyst extension. And the top portion of these figures is a comparison of the two different surgical approaches, the lysis of adhesions versus shunting. And you can see that based on these two surgical treatments, cyst size did decrease preoperatively versus postoperatively, the first 2 bars versus the second 2 bars on the right. And then furthermore, the bottom 2 graphs demonstrate the overall trend in cyst size and cyst extension pre and post-op if combining all these groups. Again, these are small numbers. So in terms of complications, and in clinical outcomes, this is I think probably a very important feature of this particular clinical series. They were unfortunately quite common to see persistent symptoms despite surgery. Again, this is only the surgical patients that were treated, and you can see that about 2/3 of them continue to have persistent sensory motor function issues. So in terms of discussion and my conclusions from review of this paper and review of this pathology in general is a rare, challenging problem. The paper here demonstrates a similar prevalence and epidemiology reported in other previous case reports. The strength of this paper is that it's a very large cohort, which did a very nice job of following their patients over quite a long period of time. And surgical treatment for these certainly may decrease the size of the syrinx, yet this does not necessarily correlate with the clinical symptoms, which is important. And then the last bit, persistent recurrent clinical symptoms are common, unfortunately, despite treatment. So when I guess my last comments here would, it's important to kind of ask the question of, what's going on when you see a change in size of a syrinx? What's occurring physiologically, biomechanically? Is there some kind of inflammatory process that's occurring? So when these symptoms arise, how might the CSF dynamics have changed? Is there progressive deformity? Is there some kind of new or worsening inflammatory process? Is there some kind of continued gliosis causing traction on the cord? I think it's key to address that question before you look at the actual treatment.
Great. Can you go back to thoracic? That's a very nice presentation. And, sorry, are you done? Yeah. Can you go back to the thoracic case? So question to Dr. Oskouian, I think this is your patient, and this is a really helpful overall vignette, very rich in substance. Dr. Oskouian, so there are 2 things to consider here: CSF flow dynamics to this extramedullary mass, and then a pretty substantial and likely ascending syrinx that is now causing impairment of the cervical cord. So can you briefly just discuss what your thoughts are in terms of reducing this extramedullary CSF compressing lesion, thus allowing better CSF flow and maybe creating less of a piston effect in the intermedullary space? And then it seems from the Falavinia paper, Abdul-Jabbar is a great friend of ours, that maybe shunting is just not effective, or maybe myelotomies and expansion duroplasty is a better way to go to be more definitive about trying to drain that cyst.
I mean, I think what Mark discussed is really important. There's it's like multifactorial. This patient specifically, unfortunately, is an Asia A. And even though he's an A, he's still got arm and he's got a lot of function with his upper extremities. So he's starting to feel symptomatic from it. So I think there's an obstructive component to this. So the question for me is, do you decompress, extend the fusion, and I usually put in a syringo pleural shunt. I think if you put in a syringo peritoneal shunt, it's not likely to work as well. So, I mean, I think this is an interesting case because the syrinx has gotten worse over time. So I don't know what your guys' thoughts are, but I'm thinking about extending the fusion and as a first step, just decompressing rather than throwing a shunt in. I was going to save the shunt for later. I don't know what you guys think.
So here are my thoughts. So a friend of mine who's a spine surgeon who we all know here was a T2 Asia A paraplegic, extremely active, wonderful colleague, again, spine surgeon. It's one of our community's bicycle crash, vehicular car assault victim. And he had 10 years of great function, and then he had an ascending syrinx, and he performed physician-assisted suicide when he lost one of his arms from an ascending syrinx. He basically became monoplegic at that point in time and did not want to live like that as a very active person. So this is always very near and dear to my heart. I would do anything here. I would absolutely give this patient a decompression and take the fusion lower. But my question is neurologically, from a neural tissue decompression, doing a myelotomy and an expansion neuroplasty, wouldn't that be a more definitive answer than trying to shunt these, with any shunt usually gluing up and getting clogged up within about 2 to 3 years, right?
I have had really good success with cerebral pleural. So I think you have to use a large catheter. You can't use a small one, and put it in the pleura. So I've got a couple cases where you show pretty dramatic resolution of the syrinx.
Dr. Abdul-Jabbar?
I was just going to say, one of the questions that I don't know that this study really focused on is, although people will have persistent symptoms, are you arresting the decline? And I think for patients with severe myelopathy, for instance, not many of them, some of them will not get better, but many of them will, preserve the function they have. And I think for some of these patients where they have an ascending syrinx and they're losing hand function, if you're able to maintain what they do have, I think that's a valuable operation. And, I think that could have been addressed a little bit more directly.
In my late friend's case, clearly, this point is very cogent. Having maintained function, he would still be alive with us now and functioning, but this did not happen. So thank you, Mark. Really well done. And last but not least, super exciting, but we're sadly down to 10 minutes, Dr. Cliff Pierre, who came over to us from the East Side. He's one of our wonderful research fellows, and he's doing further clinical training right now. And he's going to talk about neuromodulation in this era of Elon Musk and Neuralink. Obviously having some form of a neural enhancement through neuromodulation is kind of cool. So Cliff.
Yes, good morning, everyone. Thanks for that kind introduction. As Dr. Chapman had mentioned, in a new era of technology and neural rehab, over the past decade or so, we've had reached new moments where we can see that there's redefinition of the limits of recovery. And what used to be considered science fiction in terms of walking after paralysis is now in scientific reach. So this paper will go into further details. I'd first like to start with a brief clinical vignette. We have a 29-year-old female who's healthy and fit at the time, was a professional trapezist, had fell off her trampoline, head down crash, and sustained a very severe, devastating injury, bilateral C3-4 fracture dislocation. Thereafter, with an incomplete spinal cord injury, she was enrolled into a neurobiotics program about 4 months after her injury. And the way it works is this hybrid assistive limb exoskeleton includes this biofeedback. And so as the patient continues to get stronger and work and get increase their endurance and strength, the robot decreases the level of assistance. And so here's this same patient, as we see, is in this device, again, from a Japanese company, Cyberdyne, is walking and performing with the therapist, and then over time, will continue to get stronger. For the sake of time, I'm just gonna speed it up. This is about 12 weeks afterwards in a very rigid protocol. Again, we've had experience working with our colleagues in Germany as well as Japan with this device and here on site. And then this is, again, 3 months afterwards. She's working with the therapist. again, improve function and ambulation. And now is only really relying on one single therapist. And as you'll see later on in the video, just with some mobility aids, is able to improve her function, ambulation, strength, speed, and overall. And so this leads us to this paper, just published last year from UC Irvine, Brain-Computer Interface Lab, postdoc scholar Dr. Lim and the senior attending Dr. Doe, discussed again what would be the usefulness of embedding a bidirectional brain-computer interface for ambulation. Again, this has not been done before. In prior past, they used a functional electrical stimulation. With this neurobotic device about 10 years ago, and this was published, this figure you see on the right, again, tons of external systems, external hardware. You see the computer here in the background helping assist. And so one thing that they wanted to do was demonstrate if you were able to do a electrocartography interface and see if that can help control the robot itself. And this is a 30,000-foot overview of the whole paper itself in a single patient. And it was done wirelessly. So they had chosen a 22-year-old who had ECOG for epilepsy as a test subject and placed the electrodes over the primary motor and sensory cortex. One thing they were able to do in real time was decode the stimulation, and the feedback loop would essentially, after the robot had intended movements, would return a signal back to the brain in simulating the sensation of movement for the patient. So here's the patient lying in a bed. They're seeing the robot and cueing it for intended movements, and the brain itself is controlling the robot. And then afterwards, the robot is returning these leg sensations back to the brain to mimic this natural walking. And so this is just some representative images. Again, this is the ECOG and the electrodes overlying the lateral cortex there. And then again, here you see the brain waves. And one thing that you note is the areas of stronger signals were critical for more accurate control of the robotic legs for intended movements. And then this is just showing the alternation between movement and rest, some of the wave patterns disclosed here. And then for the sake of time, the results of the study. They did 5 different trials, and one thing that they chose here, this channel 59, represented most specifically the right limb, and here it shows where the subject was able to feel sensations that were stimulated by the brain to the robot exoskeleton itself, and this was production of clear, comfortable tingling within the heel of the patient itself. And then again, these were the measurements that show the brain signal decoding. The signals, the scores that are closer to 1 means better accuracy. There was one channel that had a lag, and we'll discuss that a little bit later. And then again, this is just again showing alternating online decoding in real time of the patient thinking they're walking and controlling the robot. And so one unique part of this paper itself is the first human demonstration of a embedded bidirectional brain-computer interface to control lower extremity function. It showed high decoding accuracy, close to 80% correlation between the intent of what the brain wanted to do, as well as the robotic step initiation and then the sensory feedback loop. Some of the limitations, it was only a single patient. Now, they need to test it in a spinal cord injury population or specifically overground walking population. As you saw, the subject remained stationary as they controlled what the robot wanted to do. And so that limitation itself, not walking doesn't activate what could happen in terms of spinal cord injuries, motor cortex plasticity activation, some things that discussed earlier. How does spasticity, how does autonomic dysreflexia that many spinal cord injury patients face, how can that also play a major factor in the ability of the brain to control some of the stimulation itself. And then one thing they did was alternate decoding and stimulation. That one channel that lagged could be potentially a result of this alternating versus a simultaneous stimulation and mapping, which happens with natural walking. And so that was one of the limitations of this paper as well. But it does play into what we talked about, the future and Neuralink and other devices in terms of the ability to control exoskeleton with your brain, mind control essentially, and help some of these patients that are severely disabled from spinal cord injuries, paraplegics, to can regain function of motor. And so that's one of the unique things from the paper itself. And so this was just the main conclusions: restoring motor intent and sensory feedback using a brain-computer interface device to help real-world ambulation and restoration in spinal cord injury patients.
That's wonderful, Cliff, and that's a great way to end, and we'll just have brief time for some questions and answers. Can you go back to the video of that patient in the beginning? That patient was treated in Bochum. We actually had with her with the HAL device on. When I recognize the Japanese company called Cyberdyne, we actually did 18 patients here in their pre-FDA thing. These patients are incomplete cord injury patients. And it does show the power of maximizing hyper-intense rehab. Our study was shut down when COVID hit, and our administrators understandably maybe got cold feet. And these are very energy expensive things. So sadly, we ran out of funding and we've not reignited this. But this technology in incomplete patients already leads to astounding early recoveries. The problem that we ran into is the following, and if you can just keep that loop on with that lady walking on that band, is the price. So there was no way to get this funded by insurance carriers. The hospital basically ate this. And the costs of even this are fantastic. The returns are amazing. What this black box that's pixelating out the face of the patient does not show is the smile on the patients and the independence of standing up. But the price that society/hospital systems would have to pay for this is fantastic, even for this. This is in the hundreds of thousands of dollars. I've heard that these brain interface patients cost between $1 and $3 million a year.
Wow.
So how is this supposed to be funded? Who's going to fund this?
That's a very major question. I'm not sure if we've had resolve to figure that out. But again, the results are in the pudding. I have visited the site downstairs in the Musculoskeletal Research Center and was able to see that because patients with MS, patients post-stroke, were able to also see much benefit with the Cyberdyne as well, not just spinal cord injury.
Yeah, we had 3 cohorts, so this is why I decided to never publish it, because basically we did stroke patients, we had neurodegenerative patients, mainly MS, and we had spinal cord injury patients, and all 3 populations benefited, but the most important were the spinal cord injury patients, and by far, in terms of disease regression, actually, MS patients. But again, anybody want to donate a couple $1 million, we'll be happy to rekindle the study.
We would be able
But the point is that these things work, how to commercialize this, I have no idea about. Dr. Abdul-Jabbar.
Yeah, I would just bring up, I think this is, amazing new technology. But, on the same front, we're using older technology for incomplete spinal cord injury patients, just using regular spinal cord stimulator paddles to kind of potentiate incomplete cord injuries and seeing some good results with that. So I think there's a lot of potential here. And as these things are more common, again, that implant was placed for a different reason. And seeing that it can be used, I do think the cost will come down, but there's a lot of potential here to make people's lives kind of much improved in terms of quality.
Closing statements, Dr. Oskouian, do you want to reflect on the 4 topics today and tell us what we can do better?
Honestly, I think this is a really remarkable, if you look over the last even 10 or 15 years, it's amazing what between AI, robotics, and Jens, you didn't mention that you got this approved through the FDA.
Through FDA, yes.
This was a landmark study that Jens piloted, and it's truly remarkable when you think about what you're doing here with Cyberdyne. Where you're stimulating your reverse stimulation, and what they showed in stroke patients, and Jens didn't bring this up, you get cortical reorganization. So part of your brain that had a stroke, the neurons there, the cell bodies might not work, but then through these axonal connections and dendrites, you can create new areas where function comes back, and they showed it with functional MRIs, and to me, that's remarkable.
Yeah.
You know, so there's lots of cool stuff happening.
Yeah, they described that previously in the neuroplasticity of
Yeah.
the brain post-stroke. We were able to, present that with the fMRI studies.
And it got FDA approved in the US. This is a huge thing.
Yes.
Yeah, so this is FDA approved, but again, the monetary aspect remains highly problematic. And again, in this area of cost cutting and how we have so many holes to fill in our general healthcare situation of an increasingly ill and aging society, this is very contentious, and I don't have an immediate answer. But again, this is a call for philanthropy because this exists. This can be put to greater use, and maybe we can reorganize this as a far larger prospective study. For the patients involved, it has unequivocally been amazing, certainly incomplete patients. And for complete patients, this opens up a whole new, literally, door that they can open themselves.
They can, yeah.
And take things out of their shelves and stand at eye level with patients. That's one of the main things I heard from patients. They're grateful to stand in front of somebody at eye level and shake their hands.
Yes.
On that note,
Just walk on this.
I want to thank our four fellows for suggesting this topic and not just reiterating alignment goals on spine care. It's a call for spine surgeons to be actively involved as advocates for a spinal cord injury population, which is growing in a variety of manifestations, and interacting with our colleagues to kind of help our cord injury patients be prevented in terms of the injury mechanism and optimizing their life. Thank you for your interest, and thank you for doing this great job here.